Hello everyone, welcome to Pathogenesis, and today we'll be learning about the infective endocarditis, which is a topic of general medicine. We'll start with the definition of infective endocarditis. So now the definition of infective endocarditis include the main three words, which is microbial infection of mural endocardium, which says that the microbial infection will be affecting the all over the endocardium of the heart. So what is the endocardium? It's a layering of the heart, and also it affects the heart valves and also the lining of the blood vessels. And also the infective endocarditis could be a congenital defect, which is also called a septal defect. So this infective endocarditis can be sudden or prolonged, and the classic lesions would be formation of infective vegetation, which is a mass of platelets and fibrin, and also could be an aggregation of microorganisms. So there will be a classic lesion of infective endocarditis where we can see a vegetation of platelets and also some fibrins and also some microorganisms. So this is a classic vegetation of infective endocarditis. If there is a non-infective endocarditis, it could be a thrombotic vegetation infective endocarditis. So coming to the types of infective endocarditis, we have acute and subacute. So coming to the microorganisms, so we'll just divide them into four main headings to differentiate between acute and subacute infective endocarditis. So first one is the microorganisms affecting these diseases are for acute infective endocarditis are more virulent, where the subacute are low virulent. And it involves in acute, normal and damaged vessels are involved, whereas coming to subacute infective endocarditis, it only affects the damaged vessels. It does not affect the new blood vessels, but it only affects the damaged vessels. And then systemic manifestations, this acute one will be metastasize from one place to another through a metastatic foci. So coming to the subacute, it will metastasize through bacteremia, toxemia, and also through immune complex formation. So there is only a foci where from one part of the body to the other part of the body. Where coming to the subacute, it could spread through blood, through toxins or through bacteria, and also immune complex formation. It could also reduce the formation of immunity like immunoglobulins, and also valve destruction. So what type of valve destruction does occur in acute and subacute? In acute, it is common. The valve destruction is so common that it could occur in mitral valve or aortic valve, and it could be mitral or aortic regurgitation. So what does this regurgitation mean? It means the valve does not close properly, which leading the blood to flow back into the ventricles. And also we can see the perforation of valves in the acute infective endocarditis. And then in subacute, the valve destruction is uncommon. If it is present, it leads to embolism. It could be due to embolism. The valve destruction could be due to embolism. And if these acute and subacute are not treated or will be untreated, it could lead to fatal. It could lead to death of the patient. But acute one, if it is not treated below the 6 weeks of the infection, it could be fatal. And now we will be seeing the organisms causing infective endocarditis. So As we discussed earlier, we have two types, which are acute and subacute. In acute, the organisms which cause acute infective endocarditis are Staphylococcus aureus, Streptococcus pneumoniae, and Neisseria gonorrhoeae. So these three are the main organisms causing acute infective endocarditis. While I come to the subacute, it could be due to many organisms such as Streptococci viridans, the species of viridans, and Enterococci, and Staphylococcus aureus as the same as acute infective endocarditis, and also some gram-negative bacilli and Haemophilus species, and the most important HAC bacteria. The HACEK is the mnemonic to remember. H indicates the Haemophilus bacteria, and the A includes Actinobacillus, and C is Cardiobacterium, E is Ickenella, and K is Kingella. So these 5 organisms are the main cause for the infective endocarditis. And these are not bacteria, but the fungi and other ones could also cause the infective endocarditis, which is Rickettsia, and fungi, which is Candida. Coming to the potential source where this bacteria can grow. Now, this Streptococcal viridans and Staphylococcus aureus and HAC bacteria could grow on some common areas such as skin, throat, and upper respiratory tract. But these are mostly present on these 3 sites, but will not cause any infection. But commonly, if they are at high number, they could cause a periodontal infections. And these live at commensals where the transient bacteremia, it could occur due to these infections, or the infection due to these bacteria could occur due to bacteremia or chewing or brushing techniques. Streptococci species could be present at bowel or urinary tract, where they could enter into the bloodstream through pathways and enter into the blood as bacteremia and endocarditis. Now coming to the Staphylococcus aureus, which is most common bacteria for infective endocarditis, which causes both acute and subacute infective endocarditis. It could enter due to the infected intravenous cannulae and infected needles by drug abusers, not normal ones but drug abusers, and post-operative wound infection. If the wound which is not cleaned properly and which is not dressed properly could lead to Staphylococcus aureus infections and leading to infective endocarditis. And now rectaceal, which causes Q fever endocarditis. This mostly does not cause the endocarditis, but could cause the symptoms of fever and other systemic manifestations. See, this could occur in the patients who work in farm or work with the farm animals, and it could cause abscess and embolism in the blood or the blood vessels. So if the patient is affected with infective endocarditis through this species, or the mortality rate is high in those patients. And coming to fungal is mostly through the IV drug users, because the infected drugs or infected syringes could cause the fungal infection in the blood, and also due to the patients with immunocompromised health. Mostly the HIV patients and diabetic patients are more prone to this kind of immunocompressed infections. Now I come to the pathogenesis of infective endocarditis. So it is that patient should certainly have an endothelial injury through which the bacteria could enter into the bloodstream, or the hemodynamic events through some transplantation or through some blood donation, or some should either have an injury or he would expose it to the unsterilized environment where bacteria get exposed. Then if an endothelial injury occur, then the bacteria will get into the blood. Bacteria settle at the high flow rate in the heart. It flows through the blood and reaches the heart. So what is the highest flow rate in the heart? It is right ventricle, or opposite to the ventricular septum, and then the through the right ventricle, it reaches alternation the blood flow and development of sterile vegetation consisting of the, as I said you earlier, and then it forms a classic clot or classic fibrin. As discussed earlier, it has platelets, it has fibrins, and some microorganisms are involved in that vegetation. And then streptococcal viridans, which causes bacteremia, common at dental manipulations, extractions, and tonsillectomy. Presence of gingival diseases or dental infections could also lead to entering of the bacteria into the bloodstream. And then it commonly involves the left side of the heart. Right side, drug abusers through staphylococci species. And now embolization. So now what is embolization? So where the vessel is present and then a clot of platelets or fibrins are deposited at the blood vessels, causing an obstruction in the blood flow. So now this is known as emboli. This could be attached or this could be freely floating in the blood vessels. So now this is a characteristic feature of infective endocarditis, and this could be fragile or detachable. So moving. Now in acute infective endocarditis, this is septic and produce infractions and small abscess which causes the meningitis. So in the brain, in emboli in the major arteries, which can lead to meiotic aneurysm. In this, the aneurysm, the blood vessel could swell a lot. The blood vessel could bulge or swell severely due to a fungal, bacterial, or viral infection. This bulging or swelling of the blood vessels severely due to a bacterial infection is called as meiotic aneurysm. So now what is the systemic manifestations of infective endocarditis? So now I have divided them into I think some 6, 7, 8, 9, 10 and 11 components, which are very easy to learn. So first one is general. So generally what do we see? We generally see fever, nausea, weight loss, and night sweats. And then coming to heart, the main thing is heart, tachycardia. So what is meant by tachycardia? Increase in the blood pressure. And then murmurs are seen, heard, and conduction defect could be seen, and cardiac failure can be affected. So now coming to the blood vessels, the second most important thing, where the loss of peripheral pulse due to formation of embolism. So what is meant by peripheral pulse? The flow of blood can be sensed, but due to causing of emboli in the blood vessel, the flow of blood cannot be pulsated through the physical examination. And then gangrene on fingers and foot could be noticed on the patient. And coming to the CNS, the common thing is headache and hemiplegia. What is meant by hemiplegia? Paralysis affecting one side of the body. So hemiplegia or the monoplegia only affect the one side of the body. As already said, CNS, which is a nervous systemic defect, it only affect the one side of the body. Other side is normal. So, but in CNS, hemiplegia or monoplegia is an uncommon systemic manifestation, but is considered one of the important to get noted. And in lungs, hemipstasis or pleuritic pain. What is meant by hemipstasis? Blood mucus. So when the patient cough, when a normal patient cough, we could see a normal mucus, a white cloudy mucus could be seen. But in the case of hemipstasis, the mucus is fully filled with blood. So that could be a manifestation in the lung. And then pleuritic pain, where the pain could be felt all over the outside of the lung. And then sixth one is nails. Commonly we see clubbing in any kind of disease, and then hemorrhages on the nails or on the peripheral parts of the finger, and Osler's nose. So now what is meant by Osler's nose? Tender swelling at fingertips. So the fingertips would get swelled a lot. So this could be tenderness and painful. And then at skin, petechial hemorrhage. So now what is meant by petechia or petechial hemorrhage? A small white dotted like appearance on the skin is known as petechia or petechial hemorrhage. And purpuric spots, same as these spots, are also erythematous spots seen on the skin. And on the eyes, a petechial hemorrhage is also seen, and rough spots. A white scented retinal hemorrhage. See, assume if this is a retina, so there is a white spot, and that white spot is covered by a retinal hemorrhage full of blood. So now this white spot is noted with the retinal hemorrhage. So now this is a systemic manifestation in the eye. And now this petechial hemorrhage is seen around the optic disc. In kidneys, hematuria, which is blood in urine. And then acute phlantic pain due to embolization and development of focal glomerulonephritis. What is flank pain? See, if this is a back, and if these are hands, and this is a shoulder, hip and legs, so the pain over here is acute flank pain, where the pain which is experienced peripherally of kidneys. So now that is an acute flank pain due to embolization and development of focal glomerulonephritis. And in spleen, it could lead to splenomegaly, and in blood, it could cause anemia. So investigations include blood examination. If we do a blood examination, we could see leukocytosis and normochromic anemia. So the RBC size is normal, RBC shape and color is also normal, but anemia is present. And we can also see erythrocyte sedimentation rate is elevated. And in urine examination, mild proteinuria or hematuria is observed. As discussed earlier, in the kidney functioning, hematuria is seen, and also the proteinuria due to glomerulonephritis is also seen. Now, if we do in blood culture, we could actually experience the positive blood culture. We'll be taking 3 to 5 cultures of blood of 20 to 30 ml at 1 to 2 hours of interval over 3 to 6 hours. Over 3 to 6 hours, we'll be doing the process, giving an interval of 1 to 2 hours, but the random blood taken is 20 to 30 ml. While we also conduct a bone marrow culture, and next one is ECG, and conduction defects and myocardial infarction due to coronal embolism can be detected. Echocardiograph, high risk patient, only the patients with high risk could get notified in echocardiograph. Large vegetations can be seen. Pre-existing vascular lesions and vascular enlargement due to volume overload can be seen. If in echocardiograph, if pre-existing vascular lesions are not observed earlier, it could lead to high risk in the patient, where the large vegetations are formed. Vascular enlargement due to volume overload is seen. And then in chest x-ray, cardiomegaly is seen. While coming to the treatment or antibiotic therapy, penicillin can be given. If the penicillin is sensitive, if the penicillin is resistant, we could give vancomycin. If the bacteria is penicillin sensitive, we can give penicillin G along with the oral amoxicillin, and also vancomycin is given individually. If penicillin resistant, vancomycin is given individually. Cephaloxime is given for the pneumococci infections, and if Staphylococcus aureus, the cefazolin and nacifilin is given. And if Staphylococcus aureus is methicillin sensitive, if it could react with the methicillin and get destroyed, the cephaloxime is given. And for the HAC organisms, ceftrioxime is recommended in use. And thank you. If you enjoyed the video, and if you gain some at least 2-3 points of knowledge, please hit the like button, please hit the subscribe button, and share to your friends.